Shatal, welcome. Today we'll be talking about reducing the stigma regarding mental health and its treatment with the right words. And your panelists today are myself, Vipul Vyas, Head of Vertical Strategy at Persado, and also Head of the Healthcare Services Administration Concentration at the School of Management at the University of San Francisco. And with me is Shatal Shah, Senior Vice President of Access at Woebot Health. And Shatal, maybe I'll give you a minute just to give yourself a fuller introduction.
Oh, thank you for having me. Well, really looking forward to the conversation today. We know we hear a lot about mental health needs in the U.S. and globally, especially an area that you've got worse with the pandemic. So really looking forward to the conversation today.
Yeah, and I think I'll kick things off by setting some context in which you can bring your expertise with regard to mental health and the latest approaches and technologies being used to address it. And with that, for the benefit of the viewers, I'll dig into some important statistics. One is just ostensibly on the surface, we as a society are doing materially much better and better over time. And this is a graph that shows per capita GDP in the US over the last nearly 30 plus years, close to 35 years. And so during this period, things have gone well, at least from a, as I said, material perspective. At the same time, though, we're not seemingly very happy. And that's getting worse in terms of anxiety and depression, represented by the two lines, the red and the yellow there at the top, are actually getting worse over the past decade. And while your sort of classic ideologically more certain disorders like bipolar, schizophrenia, which affects about 1% of the population, PTSD, et cetera, have remained relatively stable and predictable as a percentage of the population, the others have skyrocketed. And we'll get into a little bit more, but Shatal, any thoughts as to what's been happening to drive this?
Well, what a unique observation when you've juxtaposed material or sort of material needs around GDP and overall there compared to a measure of happiness. I mean, look, you're right? The reflection of overall growth of the economies look good, but I think what's hidden in these numbers is there are groups that have been that actually have not materially have had growth, right? And they're not reflected in those numbers. If you look in the U.S., 1 in 5 of U.S. adults experience mental illness. It impacts specific subsegments of the U.S. population even differently. Like 32% of adults who are mixed or multiracial suffer from depression. We also have it impacting a adolescent market, which what's interesting is, according to the National Association of Mental Illness, I think it's 50% of lifetime mental illness actually begins at the age of 14 and 75% by the age of 24, right? And so it's a problem that will continue to grow if we don't address even more upstream with the adolescent market. So, but beautiful observation you have here with material versus.
I think yours is actually better. I think what you're saying is this may be an aggregate, but there's a lot of people being left behind.
Absolutely.
Here in this growth. That's resulting in this, and it's kind of hidden.
Yeah. The health equity angle, which I know we're going to speak to a little bit later, is an aspect that is left off. It's hidden in the data that we don't necessarily see above the cover.
That's interesting, and I think the way this manifests itself is that the suicide rate in the U.S., unlike the rest of its OIC developed country compatriots, it's this orange line buried in here, has actually been the one that's rising recently, most pronouncedly. And the US went from being a relatively low pack, member of this club, if you will, in terms of having a relatively low suicide rate historically, when you look at back to 1980 to now being the highest. And that's a profound change. Fortunately, in aggregate, suicide rates among these countries has come down, but the US is the one outlier where it's risen. And we do stand out in that regard. And as you just said, anxiety and depression among the young has skyrocketed in the last 10 years. And this is from 2017. I'm sure COVID made it even worse, but
That's right.
within the 12 to 17 cohort that you were just addressing, 14-year-olds, it's been rising pretty steadily. And that's a pretty alarming development. Where, historically up until probably 10 years ago, was somewhat flat. And then something's definitely happened over the last decade. It'll be interesting to kind of delve into what some of those drivers are. And last kind of thing I'll mention is it's also one of the top 10 reasons why people go to the doctor today.
Actually,
Might have gone up from there more recently.
Yeah, the latest numbers that we're seeing with our team at Woebot is like 1 in 8 emergency department visits are related to mental health. 1 in 8. Just if you think about that for a moment, like it's a huge cost center that obviously, like you have here, there's a connection between mental health and physical health, and if you look at suicide rates, sadly, the reasons that you have those is because you don't have access to care, because at least in certain parts of the world, including here, we don't necessarily treat both physical health and mental health the same parity in terms of coverage, in terms of affordability, and in terms of access.
Is there some structural reasons why that's the case, like reimbursement models, things of that nature, or is it just awareness?
So I think one, we're starting to come to, like, these numbers are obviously out there. There is more sensitivity now to mental health, and I think we all have seen either our companies or health systems or payers start taking more interest in this area. So one, I think that our ears are more open. You see celebrities talking about it. We saw the impact after the Olympics, and these individuals that we all look up to are more open to talk about it. So one, things are changing, and it was hard to talk about it before. And I know we're talking about stigma in a bit, but two, I think there is already a legislative push to improve access, and sort of going in and forcing parity, that the same level of availability of providers, the same reimbursement are there. So behavioral health professionals are available to consumers, just general users. And I think in California, it's AB 988 is on the legislative agenda. It's a bill sitting on the desk of the California governor. Surprisingly bipartisan, almost unanimous, if not unanimous, support behind the bill that would set the structure to ensure that health plans, both commercial and public plans, provide access to care within 10 business days. And that may sound like a very long time. Right now, there are parts of our country where a wait list could be 90 days, 120 days. So I think those are some of the observations that we've seen.
120 days, you're either something's gotten materially worse or gone away, I suppose, in the ideal situation. So that's, it's not.
What are the costs of the wait list, right? The number of adverse events that happen because you're on a wait list, the emergency department visits, or sadly another one, right? It goes back to a couple charts ago.
Yeah, suicide. Yeah, exactly. It's the ultimate adverse event. I think, one of the things that we can kind of get into now maybe is what is anxiety and depression, at least some of the, initial layers of mental health and how these form. and how certain behavioral therapies can intervene. And just for the benefit, folks, when we say anxiety and depression, there's obviously a Venn diagram overlap as this chart depicts, but it is a constellation of symptoms that are manifesting, physiologically. So it's not just kind of quote in your head. They manifest in a very real, observable manner, and they come from a sort of progression of stress that moves on to anxiety or depression concurrently, but definitely progresses to depression, which I think we're learning more and more is something that is physiologically real. It's a change in the brain. That's a function of this prolonged chronic stress that we probably didn't evolve to handle. We were probably more accustomed to acute stress. And once that saber-toothed tiger was no longer a threat, the stress sort of went away. But we now bathe ourselves in stress and the associated hormones that get released with stress. And this kind of progresses to real neurological changes. I'll pause there just to let you add, any commentary you might have to that.
No, and right. I think the next slide you're talking about how this then goes down the path of only the anxiety cycle, but then impacts the physical wellness of an individual.
Yep. And I think, the stress then kind of results in some physical, naturally evolved responses that then the body kind of doubles down on, and you get these stress hormones. And we know that stress hormones like cortisol, and there's a whole array of them, actually work to do things like suppress neurological repair and neurological function. And they also physiologically go on to dampen the immune system. They almost work as a yin and yang. If your stress hormones are high, your immune system is dampened because your body's shifting energy, some way of framing it from one system to the other. And so you have the whole cascading effect of negative physical consequences, and then you become sort of more attuned to that stress. And then even beyond this anxiety cycle that's depicted here, you can try to self-soothe that stress and anxiety with addictive behaviors, whether that's overeating or alcohol or drugs or other substances. This becomes then also injected into the cycle, which creates a whole nother set of problems.
Yeah,
that emerge.
Like 18% of US adults that have mental illness have a substance use disorder as well too. So the ripple effect, to your point, unfortunately, it's a very heavy train. It's hard to stop.
Right. And I think in more recent days, with COVID, and the specific stressors associated with COVID are listed here along each side. This has become even more acute. If we had a mental health crisis before, and stress is a driver for precipitating people getting into that cycle, we've definitely given people many more reasons, or the world's given people many more reasons to dampen their mental health. What have you seen in terms of COVID's impact on mental health in the country?
Yeah, at Woebot, we get asked that question quite a bit. Have the numbers gotten worse? And obviously, it's an obvious answer. Yes, we see the impact in substance use disorder has increased. Individuals with perinatal mental health well-being during the pandemic has gotten worse. Adolescent has gotten worse. And as we sort of get into this sense of recovery, it exasperates what is happening now that you're back, right? Adolescents are going back to school after having, in many cases, their first years of social interaction being completely different to what they're experiencing now. And tragically, we hear stories day after day, right? Coping mechanisms haven't really gotten strong, and the like. So COVID's impact, has been obviously felt across the board, and you see that you see that from a wellness perspective, claims perspective, severity. It's prevalent and it needs to be addressed. And unfortunately, we're going to talk about stigma. I know we're going to talk about some of just the labor shortages. We need to address this. And I think there's a global effort at this point to look into how COVID's long tail is beyond the tail of the physical side of it.
Let's talk about stigma because, as we just talked about, people may have historically said mental health is quote unquote all in your head, but it very much isn't. It's a physiological experience, as we are just talking about in the previous slide. What stigma still remains, even though, and as you alluded to before, we're talking about it a lot more. That doesn't mean that it's been solved. What stigma, from your perspective, do you see that's very real that remains out there?
Yeah. Yeah. And we know that stigma is, of course, also one of those elements that's getting spoke about quite a bit. But let's even move up a notch. We talked about how mental health needs have increased over the last last 2 or so decades. Why? Like, if we know that we have these needs, why aren't they getting addressed? And I think what we're sitting at now is between 50 and 75%, and that's a very wide range of individuals that need mental health support don't have it. They don't get it. And it's a wide range because what we have in numbers, we also don't have clarity in terms of individuals not even reporting that they need mental health support, even though they may know that, right? Because there is stigma associated with addressing that. It's stigma. There's general prejudice. There's discrimination against people in the workplace if they bring up mental illness. I think that actually is getting better, but the stigma is public. It's internal. It's cultural. It's institutional in many ways, in how mental illness is addressed. Even the conversation about seeking care, right, is impactful in the words of how we access mental health services is very stigmatizing.
We had a few slides before we mentioned that one of the top 10 reasons why people go to the doctor is mental health. And this is specifically their primary care physician, not even the psychiatrist or, going to the specialist straight away. So some people do know that resource is available, but I'd imagine there's still some notion that the doctor is not who you go to for this. This is not a physical injury. It's not a cold or a flu or, classic disease. So I'm assuming there may even be some lack of knowledge that your primary care physician is someone you could potentially turn to. Now, whether they're resourced well enough to treat you, that's a separate issue. But even your entry point into medicine may not be something people understand as that they should avail themselves of.
Well, yeah, let's think about this, right? Like, so 1 in 8 reason they go to primary care for mental health, I think that number is probably small. There's a lot of physical needs that were addressed on that slide you have that probably have a mental health underlying need. So the number is likely low. Approaching a provider, like you said, I don't want to trouble the provider right now about this because I'm trying to deal with something else. Or is my primary care the right person to speak to? I don't know about you, but it's like one of those things where when you feel down, Vipul, it's like you go through the ebbs and the flows, right? And when you're going through the ebbs and the flows, when you go to the primary care, like you may not feel comfortable talking about it because it happened a few weeks ago, right? Not now, right? And so there's an aspect there. It's like taking your car to get checked in on when the engine light was on 2 weeks ago, but not now. It's still a recurring issue, but do I really want to
drives?
Yeah. And so, yeah, I mean, I actually think that number is underreported because the numbers that you see in that chart require an individual to have raised their hand.
Right. And I can speak from personal experience. I don't mind sharing that. I had a very stressful event several years ago, and I thought I could just handle it, no big deal. And what actually drove me to go to the doctor, and it wasn't even my primary care physician, it was my ophthalmologist, was I started having trouble seeing out of my left eye, and I thought I had macular degeneration or something of the nature. And I went, and I was certain that I was going blind. And he looked at me and looked and examined everything and said, no, you have something called central serous retinopathy. I'd never heard of that. And he said it's basically something that men of your age get from stress. And your retina has fluid behind it. And the other people who get this are people who take corticosteroids for a variety of reasons, and it may be to excess, to treat it as an ailment or disease. And so essentially what that told me was I'd gotten myself so worked up from sort of the stress down here that my body was pumping out so much cortisol that it manifested itself physically, in my vision of all crazy things. And then, within a week or two later, I got diagnosed with Takotsubo myocarditis, I believe it is, which is also called broken heart syndrome, which is when it's not necessarily associated with broken hearts, but when you're just so stressed that your heart starts doing funny things. So this becomes very real. And I think, as you were just alluding to, that showed up in me as, hypertension, some other factors that I didn't relate to stress because I felt like I can handle it. But it turns out that I was going to the doctor for this one thing, but the underlying reason was really more likely a mental health issue, and quite directly related to stress. So I think that's something, to your point, just the stress itself, I know if I look at myself as a case study, wasn't going to drive me to the doctor.
So, Vipul, when you had that conversation, and I'm thankful that you shared, because I think one part of destigmatizing is we all feel comfortable sharing, and the like. So thank you for doing that. Walk me through the moment that maybe when your provider spoke to you about, well, you came in for this, but really in the interview, the conversation, that it's really upstream, the stressful situation that sort of built up and then created this cascade effect to this sort of physical byproduct. Like, how was that conversation with your provider?
Well, it's a good question. And these two issues, physical issues, manifested within, like I said, week or two apart. And the way that
So you had a strong signal that,
yeah, I mean, it was like you can't ignore. I was like, I'm having trouble reading. Today versus yesterday. And so I went to the ophthalmologist, as I mentioned. They, looked in your eye and they did a retinal scan, which was a piece of fancy machinery I'd never seen before, where they could actually see what kind of fluid buildup was in the back of my retina. But so it was that when they showed me the images, it was like, this is a real physical manifestation of you not taking care of your mental health, which is now translated to a physical condition. And the ophthalmologist, I would say, just said, you need to relax. You need to take it easy, you need to relax. Now, if I knew how to do that, I would, right? It's a little bit of a, yes, that is the right answer theoretically, but practically speaking, no great solutions were provided. Now, what he did to alleviate my stress was, because I was like, this is horrible. He said, typically this resolves in a few months. You'll be fine. And by and large, he was right. That's what happened. And then when I went to my primary care practitioner for racing heart and other issues that I thought I was having a heart attack. So I'm not sure why I didn't go to the ED, but anyway, I went there. And because something in my mind said that's probably not what's really going on. And they gave me a formal diagnosis. This was a thing. This had a label. And then, she said, this is upstream stress and anxiety. And then she suggested I go and talk to someone about the stress and anxiety. So she did give me a more practical intervention beyond relax, the lecture. But to get in to see someone was going to be, I think, 6 to 8 weeks. So I didn't ever go see anyone, which I think plays out to what you've been talking about, up to this point in the conversation. So, and this heart ailment that I had got, created, manufactured through stress very acutely, is something that, takes about a year to recover from. So it had long-term profound, impact as well. So all that is to say that now at least I am now, but it took it took this to happen for me to be aware of two things. One, that I was not mentally well, and two, that mental unwellness could have this impact, could translate to some, really profound physical harm. So I think, to answer your question, I didn't think that was something I'd go to my doctor for. To be blunt.
And then when provided a suggestion or a referral to speak to someone, the wait was 6 to 8 weeks.
Right. And to be honest, my probably initial reaction was, I could probably just de-stress myself. If that's all it is, if it's stress, I can handle that myself. Which, to be blunt, if I could, I would have, or I should have. If I was really in tune with what my mind or body were telling me, I would never have let it get to that state. So clearly, I was not. Let me just put it directly, competent enough to do that, to intervene for myself. And a lot of it was education. I didn't know stress could do that to you. Yeah. I didn't know stress could, progress to these things. I didn't know, fortunately for me, it didn't progress to depression and then, worse things that then, spiral. Mine took this odd path where it was sort of a red flag in my face. Many other people don't get that benefit of it, saying something to them like that. Instead, it sort of just spirals into depression, and sort of them not being, incapacitated by that depression. So I'm sorry, I guess to sum up the answer to your question, I just didn't know that's something the healthcare system could do for me, one, and two, that I had the issue. And I wasn't, even though I feel like I'm fairly educated on the subject, I didn't know what to look for.
Well, I think there's like 8 points that and I believe Vipul will be sharing this with the audience later in terms of some resources, but the National Alliance of Mental Illness had a few suggestions on reducing sort of stigma to help individuals sort of reduce the impact of mental illness and reducing the stigma. And one of the things they talked about was talking openly, sharing on social media, check, right? We're talking about it now. A lot of people are. Be conscious of the language, and the words that are used obviously matter. And then be honest about treatment, right? Like they talk about normalizing mental health treatment, just like we treat other physical healthcare impairments. And so I think we're talking about those few points now in terms of the stigma associated with, bringing mental health to the parity of physical health, right? You have an ear infection, you go to the doctor, right? Why don't we talk like that about mental illness? I feel depressed.
Yeah, that's. I think that it's twofold for me. One is just the ability to access, number one, and number two, the education to know, like we educate people on stroke, we educate people on what to look for in terms of, dermatologically, moles that you should have checked. We, I think, still have work to do in terms of educating people on what to look for in terms of the signs of a deteriorating mental health. I'm not sure if you'd agree, but I think that's a space there. And, kind of as the next slide I was alluding to, we're spending more and more on this because we're seeing this as a growing problem. I mean, I don't know if it's avoidable. People are, as we alluded to before coming in, probably not enough. And it probably manifests itself in ways worse than just sort of anxiety and depression.
Now, this is for, and if we look at the data that you have here, this is for hard data that's coded to a visit related to mental health.
And I doubt either one of mine were coded to mental health, actually, to interrupt you. Yeah.
Yeah. But to your point, right? Like it's well connected to the physical health side. Let me give you an example. there are sort of the comorbidities that we don't talk about. You talk about diabetes and the impact with heart and the like, but diabetes and mental health. If you're diabetic and have a behavioral health underlying need, addressed or not addressed, medical spend for your diabetes care is roughly about $4,000 more per year. And so that's a number that you wouldn't see necessarily on this chart. So our expenditures on the mental health side are increasing. I think we're also not counting the people that don't get care, period. I will tell you, it's a divide on access based off of even just sheer places about where you live, rural communities versus urban. There's no spend. There's generally no availability to be seen in certain markets. So the spend wouldn't show that. So yeah, expenditures of mental health services has continued to grow. I think 24% of all mental healthcare spend, dollars wise, is actually done by Medicaid. And obviously Medicaid serves.
So it's in the poor, right?
Yeah, that's core. They're the largest spender on mental health services. So in the underserved, the undercounted communities where you have these sort of deserts, they still are consuming a significant portion, and it's still not enough, right? And I think you're
going to. And Medicare Medicaid is the state federal program for impoverished people. So it's the underserved already, who probably are under stress because they're, just in condition. In general, their life circumstances that are probably, as you said, consuming a lot of mental health. And to answer your question, I think in my case, I was coded probably for central serous retinopathy for my eye and Takotsubo myocarditis for my PCP visit. So nowhere probably did the mental health part, and so it would not even show up potentially on this chart. And those were 2 doctor visits that were probably several $100s at the least in total that don't make it here. Yeah, it's a fair point. I think the other thing that I think we were talking about before is just that 1 in 4, it looks like now, this is 2016 data, people have some mental health diagnosis, and it's again higher than our compatriots. I think Canada is the closest, in Sweden, which has a long history of this, is in our sort of group, but we're at the top of the pack, as this graph shows. And I think further, among veterans, mental health is pretty high. Women typically more than men, it looks like here, and suicidal ideation is in 7% of women who've been in the service. So that's pretty shocking in terms of just prevalence. Nearly 1 out of every 15 people has had suicidal ideation. And I think the couple other things I'd mention is that we again are sort of at the top of the pack when we talk about experiencing emotional distress and not being able to get access, which is the things what you were alluding to, is folks having this issue. Now, I was fortunate. I'm live in an area where I could get in to see that doctor the same day or within a day or 2. But some of these people may not have the same resources because they don't have the same kind of insurance plan, don't live in this communities where these kinds of resources are easily available. And so they have to power through, for lack of a better descriptor.
That's right.
I think one other point I'll make is that even when you go to primary care, depending on where you are, and again, I was fortunate enough to be in a resource-rich area, the primary care compared to our compatriots in other developed countries is not well positioned to render care or treatment. And maybe you could talk about this in terms of, what are you offered, when you go into primary care with an issue like mental illness?
Yeah, I think most, I'm going to answer this in 2 parts. most health systems, most healthcare providers are very good at figuring out when there is a need around behavioral health, when it presents itself in a specific way. Unfortunately, a consumer sort of left an individual, a patient's family. We haven't even spoken about the impact on family or those living with you that this has. But you usually are provided a set of resources, a suggestion to go visit a behavioral health professional, but then you get one barrier after another, right? Price, availability. You know, I think Vipul, you and I are very different from many people that don't have access to transportation, don't have time to take off in the middle of the day, you know, mid shift, because that was the one availability for the provider to go speak to. And these behavioral health professionals are in it to care and to deliver therapeutic sessions that really help individuals get through this. But you have to have a series of one part luck, one part have the resources to go visit. So, you know, that's my perspective. But I also think that you look at what you're asking your primary care physicians to do. Look at what the realities they hear from their patients about trying to get in, and there's a wait list of 6 to 8 weeks, 3 months, or what have you. They themselves aren't empowered to have it because the US Bureau of Labor and Statistics basically said pre-pandemic, I think this is from 2019, by 2025, we'll be short nearly 250,000 mental health professionals in the US, depending on how you classify behavioral health professionals, school counselors and the like included in the US. And so if you have a resource gate, it's very hard to drive individuals through the traditional path. And that's where I think, you know, maybe as we segue the conversation on the role of technology, and maybe we talk about artificial intelligence, about using the right words to break down stigma, right? The power of words there, but then also on the delivery side of behavioral health. You know, we're decades in talking about cognitive behavioral therapy, interpersonal psychotherapy, dialectical behavioral therapy, and the like, that really provide the self-help aspects and the like. And I think there's a role of technology here today. Like, we look at these numbers, and technology in many ways can serve destigmatizing access, right? Making it non-judgmental, making it available at a cost that's actually affordable, making it accessible at the time when you can actually get care, right?
Well, I think it's a great segue, which is we've kind of, I think, created the alarmist sentiment that this is a real problem, and we don't fare well when we compare against other comparable countries, and along all other dimensions. So what do we do about it? And I think we know that it's a problem. It's a growing problem. There's limited access. We're spending tons of money, but there's still a big hole to fill. And so there's two things. One is how do we use communication, and especially digital communication in this era, to let people know, you know, giving myself as a case study, what to look for, what are the signs, and what to do about it in terms of getting yourself in front of the right people within the healthcare space. And so it's, hey, Vipul, here's what you need to look for. Just educate me just as you would about, hey, these are the signs of a stroke. These are the signs of a mole that's going to become malignant, you know, things of that nature. And then two, here's what you do as a next step. You know, take an aspirin, go to the hospital, or go to your dermatologist, as the examples I mentioned before. The same thing with regard to mental health. Like, this is something you should know and you should get access for. And then second, with regard to the actual treatment and access, I think love to hear your thoughts on what's now possible. I mean, do we all have to wait 6 weeks to get in to see someone, or is there something I can do now?
Yeah, yeah, but you know, on the communications front, before I get into the other one, because I do have some thoughts on that one. On the communication front, I think the role of using advanced, more intelligent communications, right? And let's just use the word AI for giggles here. If a provider can destigmatize a payer, an employer can destigmatize their communication to their employee, their patient, their member by personalizing the message in a way that brings in an understanding of the psychographic profile of the individual, cultural implications, and the like, specific community-based, and figure out what resonates, right? A lot of the stuff that Persado does. I think there's a vehicle there that we can finally get individuals that aren't on some of these charts, individuals that are on the charts to actually get the right care at the right time by reducing that sort of that stigmatizing aspect of, I can get through this, I'm okay, right? So that there's definitely that. I think the other role for technology is actually some of the therapeutic interactions that we have. I think, Vipul, you said, your provider told you to, you got to reduce stress, and, how lucky are we that if that was a request, we can go do that, right? Take time off or the like. For many, it's not there. At Woebot, what we're working on is something very different. We're building, we have built a digital mental health ally, right? It's a relational agent. As a term, it's a human-computer interface that has empathy, that has clinical memory, and it's a mental health ally, a chatbot for us technologists that's trained on decades of CBT, DBT, and IPT treatment to basically break down the barriers to access, and to break down the barriers based off of affordability or judgment, right? We've built a chatbot that is having, for instance, 5 million therapeutic interactions every week, 20 million every month. After the period we've had this webinar, during this webinar, this hour that we're on this webinar, there will have been 30,000 therapeutic interactions being conducted across our million users that we have on the Woebot platform. But,
so you don't need a car, you don't need to wait, you don't need to access therapists. All you need really is your phone or similar device.
Yeah, and look, it potentially doesn't work for everyone, but we know it works for a fair amount for the number of people that are using it. In fact, to your point, Vipul, the one you just made, 78% of the way that our users are accessing Woebot is after clinical hours, after normal,
when they have time,
right? And imagine some areas around behavioral health needs, postpartum depression. You're a working mom. You're going through the first, the fourth trimester, as we're starting to use as a term. When do you have time? Right? It's 2 a.m, it's 3 a.m between a feed, and the like. So, we talk about the role of technology. We have to break down the barriers to, one, feeling like it's okay that I deserve care, right? We all deserve the right care. We've talked about physical health. We have a right to care there. You have a right to self-care, right? And we have to break down the communication barrier so it's non-judgmental. And we got to do it looking at the culture, looking at the way which words we use. We have to look at it the way we serve different communities, right? There's a cultural implication that I don't think a lot of us count and look at in the way we communicate. And so building a psychographic profile and figuring out how to communicate, really important for the stakeholders we described. But then second, the role of technology in making a non-judgmental sort of person or bot to speak to is actually very important. In fact, we're showing we can drive down depression scores 22%.
And to give people a sense for what it feels like, it's essentially using something that's established, cognitive behavioral therapy, CBT, to help people delve into how their thinking works.
Yeah.
Sort of dispassionately look at their thought patterns and see where they end up going off into unhealthy places.
Yep. Yeah. So let's talk about it, right? Like, look at at the end of the day, we don't have enough behavioral health professionals to serve the needs of our communities. If we were to build technology to serve for a portion of the care that's needed, not replace therapists, but really augment them, right? Make it easier to access at all hours. What you have to build is a relational agent that is as like a human has with another human, a provider and a patient, is to build that therapeutic bond. We call it, it's a well-known industry nomenclature on working alliance. So you have to, from breaking it down, can Woebot form a therapeutic bond similar to a human could with another human? And we've shown that our working alliance, we can. In fact, it's not inferior to that of a human to human. In fact, you could do it faster, 3 to 5 days, because guess what? Technology is available more frequently. Woebot's available more often. So establishing that therapeutic bond, think of it as the plumbing. Are you comfortable speaking to something that's on your phone, right? And then will you feel comfortable talking about things? And then can Woebot figure out, what is it that this person's talking about? Is it a relationship issue? Are they describing work stressors? And then let's take them down a treatment path through conversation, mind you, not here, watch a video, right? And that's sort of the way that we help our consumers go down that journey for mental health and the like. But again, a lot of different places that technology, I think, is actually starting to break down the barriers to talk about mental health, and then also barriers to getting care.
And it sounds like it acts as a force multiplier for the existing healthcare resources that are present. So I could use this while I'm waiting for that access to a mental health professional.
We actually get a lot of comments from clinicians that that have gotten past it's trying to replace me concept, right? But think of it as an additive effect, like you said. It can space out treatment. It can reinforce treatment, and that ultimately is the reason that behavioral health and clinicians of all sorts got into the business, right? The Hippocratic Oath.
Well, that sort of then begs a question or rolls into, you have to know that this is a resource that is available. And if you do, like in my case, go to the PCP, they give you something like this in the interim. There's also the communication with the PCP to make sure that you're staying on top of this, that you're engaging, nudging you, if you will, along, and making sure prescriptively they're saying, hey, your appointment's 2 weeks away or whatever. Make sure you're doing this as sort of your pre-appointment care, and then between appointments, because you're probably not going to be getting, to a therapist every day. That sounds like it would be expensive. But if you're going once every couple of weeks or once a month or even once a week, those periods between those sessions then can be reinforced or accentuated by something like this. But then you would still need the communication to make sure, just like we have with medication adherence, the need to communicate, to compel, to use the right words and language to make sure people are emotionally driven and doing what we need them to do to be better, that you're doing that all along the way to support the therapeutic.
Yeah, I mean, like we titled this "The Power of Words" and the role of healthcare communicators. Doesn't matter if you're part of a health system, if you're part of a payer, an integrated delivery network, an employer, public health, is to communicate that we have tools and resources available, and because they all want to invest in these tools and these resources, and and that includes your own therapist. But you have to communicate in a way that one breaks the barriers that we discussed around stigma and the like. But then, to your point, the prescriptive approach in time, right? Over a period of 12 months, how are you prescriptively talking through these scenarios? Thanksgiving is a very stressful environment for a lot of people. Okay, you got family coming back together. There's a lot of needs and expectations. Very different than, say, the height of summer and the like. And so individuals go through ebbs and flows. It goes up and down. So communicators have this really hard job. Maybe this is why really, we kind of get through these scenarios where there's always a surprise that an individual needs care, is that fact that we don't communicate in a way that recognizes that it's a journey, right? And having a prescriptive approach to communicating about needs and making sort of driving awareness through time is so important. In fact, I would tell every payer, provider, employer, public health organization is that amplifying the message at the right times for an individual through a very prescriptive communication strategy is probably key. It's not a campaign, it's a life, it's sort of an annual communication strategy.
And in my specific case, again, not to talk about me incessantly, but everyone said this doesn't get healed overnight. This is at least 6 months to a year in both, for both conditions. And so you have to stay on top of it, because these could get worse if you're not on top of it.
Yeah.
What I was experiencing wasn't the worst it could be. And I think kind of going to something you alluded to before is, with diabetes, depression and diabetes also have this relationship where they reinforce each other. The physical and the mental become sort of conflated. And I think we see that with, this is from the CDC, with, heart disease as well. The same kind of thing happens. And so if you're not careful about mental health, it will manifest itself into expensive and potentially deadly physical health implications.
Yeah, I think it's the individuals that have a mental health illness. And I will say that even using those words is probably not the right. All of us go through times where we need better mental wellness, right? But individuals that have a mental illness and they have their risk for things like cardiometabolic diseases, a few that you mentioned here, their risks for getting those diseases is twice as high. Like, to let that sit in for a second, twice as high. I recently went to the health conference, the one without vowels, HLTH, earlier this week. And there are companies that are starting to think about this. There are folks that care for diabetics that are thinking about the role of mental well-being as well now. I had an interesting conversation with an organization that runs dialysis centers across the globe. Mental well-being comes into play for many of them. In fact, they have social workers and the like, but I said, well, how do you connect the dots there? He's like, well, people that might be down or people that feel really good because we didn't communicate right might miss their midweek treatment because they're either doing really well or they're not doing really well mentally. And for either of those reasons, they might skip midweek treatment. And the role of dialysis then becomes even really harder to manage for the team.
So it's just compliance, making sure to communicate to drive compliance, because people may think based on their current state, they don't have to comply, and then they end up in a spiral in terms of physical health. And I think, with diabetes specifically, what I read was that, more directly, even in with heart disease, cortisol itself, the stress hormone we alluded to before, directly impacts, the proclivity to get diabetes if you are pre-diabetic, and for hypertension, some of these other issues in combination with other lifestyle factors is a deadly brew.
That's right.
So I think it's not theoretical, it's not abstract. And I think you gave an example of just non-compliance, and then there is the aspect of stress and anxiety and depression itself directly physiologically contributing to these problems as well, on top of everything. So it's true. I think we'll kind of close out with a few kind of points, and I think you mentioned this, is that some of the stressors, the people who really have significant mental health issues, are the folks who can least afford to, and some of the stressors that are probably contributing to their decline in mental health also prevent them from getting the help they need, as I think you alluded to before, Shatal. And then, I think this is an important point you made at the beginning. Our growth has been phenomenal in terms of material wealth, but there's a group that's left behind that is not in the same place that maybe a lot of other people are. And so for those people, there are real stressors in life, those social determinants of health, if you will, that are both contributing to mental health issues and also preventing treatment of those mental health issues. So with that in mind, communicating that this is a real issue that has real implications, referring to some of the diseases we just talked about, and the fact that there are interventions that they can take advantage of in a way that's relevant to them, that's doable for them, are important things to make everyone aware of that they may not be completely cognizant of. So I'll stop there in terms of at least slideware and just give you kind of the closing thoughts in terms of your perspective on what the next decade will look like for mental health. Are we still kind of in the hole? And is it just going to get worse, or are you more optimistic?
Well, I think Vipul, one thing that, why don't organizations act about doing something about mental health is because we don't talk about it. And I think props to the Persado and you, Vipul, for bringing this topic up. I am always a half glass full person. I think if you succinctly laid out, there's a need. In fact, while the need may seem like not as important with all the, hey, we're getting, there's growth, GDP is growing, but our mental health is not, mental well-being is not, and the impact that COVID had, you succinctly laid out the story, which it's almost like a no-brainer. Why don't organizations act in a way that helps bring to focus the need for mental well-being, brings to focus that mental well-being is connected to physical health? Because I hate when ROI comes up. What's the return on investment for mental wellness? I mean, we just described the story on how it is the connective tissue for a lot of these diseases, diabetes, kidney, heart. Your story, right? Your care probably cost a significant dollar amount that your insurance company covered, and it was all related to something that was more upstream. So as we talk more about these things, I think one, talking is good. This is what we need. But now it's, I heard an individual from Walmart say this, and it was great. There's one point about talking about it, and you get 9 points for doing something about it. So I would probably close on the part of, I think organizations need to start breaking these barriers down. Start on the communication front. Utilize artificial intelligence. It's not a threat, right? Use it to communicate with messaging that's non-judgmental, that's personalized to different communities and psychographic profiles. We do that for selling cars. We do that for selling toothpaste. We should do it for this, right? And there is a very good business case that is in the data that you've presented. And second, scale using technology like we have before. Utilize technology like that we have at Woebot or anyone else, right? Let's start getting people care at the time they need it, and let's do it in a way that is reflective of the communities and their access, right? Like you said, transportation, time of day. If I had a chance to, take a shift, I work in, say, a fast food joint, or go to my appointment and miss putting food on the table, what are you going to choose, right? Because you're not available during clinic hours. So I think, Vipul, you laid out a great story about why we need to do something, and now it's time to do something. So
that's great. And I'll close with sort of teeing off what you just said by saying that if any institutions who are participating today want to better understand if their communication on mental health is effective or how it could be more effective, we'd be happy to do a language analysis of your existing communication to your patients and members and understand how it could be better. That's something that we'd be more than happy to engage in. And you can reach out to us. We'll provide a follow-up email to those who participated today with how they can do that. So thanks everyone for joining, and we'll let everyone go. Thanks, Shatal. Yep. Bye-bye.